joined by Dr. Kavitha Kesari. She's a program director of internal medicine residency at McLaren, Flint, and she's an associate professor at MSU, Michigan State University. She's also a board certified across 4 different specialties, including lifestyle medicine and obesity medicine. Dr. Kesari brings over 25 years of clinical experience. Guys, I'm so thrilled to have her. And she is passionate about how to help and how to educate women's health. And I think I'm very much interested to know a little bit more about it. And today specifically, she's joined us to talk about menopause. Dr. Kesari, welcome to Key to You.
Hi, me too.
So let's start with that. What is really a menopause? And why is it still so confusing to people, even after menopause is being so widely known, but still people are confused when it really happens to them?
That's a really thing, because I think, menopause, if you take literally word of the meaning, men says pause, stop, right? But rather than menopause, we can call menopause transitional, because it's a time, and correctly to say for a common woman, it's a midlife of midlife of a woman going through a transition. Physiologically, your body's kind of telling you things to slow down, and a lot of stresses in the life you're kind of going through.
Right.
Some of them maybe at the career time. So that middle of the life, and because it can range like a long time, usually 45 to 55 is where most of the women fall into. And other confusing thing is, it's kind of 3 phases it has, like a pre-menopause, menopause, and post-menopause.
Okay.
So it's a better thing to call perimenopausal transition.
Okay.
So that way it ranges on to thing, and the symptoms, not all of them have the same kind of symptoms, and this, a lot of time you attribute that to aging. So by this talk, I think we can get to know what are the symptoms that may not be typical of aging or middle age crisis in women, and kind of know about more about them and what to do. So we'll kind of concentrate on that one. So that's the way I would go for it.
You really had me into my next question right there. How do you know you're heading into the menopause phase? Is it the mood swings, or is it you'll start feeling anxious, you start feeling suddenly crying, depression, right? These kind of feelings will occur, or is it a random sweat?
So you kind of asked about what they call hot flashes. More women are kind of know about. So I think we'll talk more detail, but when you ask this question, how do I know that I'm coming into menopause? Most commonly, I think, more women can kind of easily relate to is irregular in their menstrual cycle. So they're kind of facing scanty, and sometimes they may have a little more than what usual normal periods.
Right.
Along with that, they seem to be irritable, which they attribute to like their day-to-day stresses. So it's quite confusing. Why? Because these hormones, first of all, that we are kind of had a purpose of reproductive age. So this is kind of, we're talking about the woman passing off the reproductive age, getting to the next phase of the cycle, right? So the hormones kind of start getting a lot of fluctuation and kind of seizing down. The hormones that are estrogen and progesterone, which are kind of for mainly with the ovaries and the brain that we have regulation. So the transition being so different for different people and subtle, so it's not easy. And the symptoms which every woman feels it, not all would have a high intensity where they would come to the physicians. So the fact is the symptoms are so varied. So when we talk about the hot flashes that you said about sweating, so sweating alone is not a part of it, but if you take it in hot flashes. So when you have hot flashes, it's like a feeling about a sudden flush, and then blood going through, and then associated with some palpitation sometimes, or feeling dizzy, and usually sweating. So that's we identify, and then because they're so transient in some women and so subtle, you don't even kind of notice it. And some people, unfortunately, it's kind of more. So that's where people come in, and we'll talk about it's not just alone. We have other bunch of things that a woman can identify, and we'll talk about as the talk goes on. But the symptoms we talk about, So we're talking about hot flashes right now. Why it occurs, we'll kind of talk in detail when we talk about the symptoms. So that's what it is. And the second thing you talked about is the mood changes.
Yeah.
So usually if you see in a woman's life, whenever there's a hormonal change, adolescent at this time of first menses or pregnancy, postpartum, and now at the menopausal time, there's a hormonal fluctuation.
Right.
Especially the estrogen being going down at the same time seems to make mood changes in a woman, like a more depression, sadness, kind of feeling lonely, hopelessness.
Yeah, and also feel irritated. And during those times, I can relate to. I'll say, those are the times I'll be so very easily irritable, and I'll tell my husband, do not even talk to me today. Sometimes it does come up like that.
So you can see that fluctuation even before you get to menopause.
Right.
If you remember PMS, like women talk about, 15 days before the period, the hormones dropping down. So I think, we can relate that to PMS to the menopausal, but menopausal, it's a little longer.
Right.
Usually the median age is like 1.5, and some people in literature, it kind of goes to up to 7 years.
Okay, wow.
Now we're talking more about the menopause because famous people like Michelle Obama and all mentioned about the menopause and got attention really on the menopause really from last 30 years.
Right.
And a lot of it, if people get interested and they want to kind of look in what is called SWAN. It's a study of a woman in their middle age kind of thing. It's a 30 years across all the nations. It's a multinational one. It's kind of concentrated on of the woman transition, and they talk a lot about menopause.
Wow. It's one of the subjects that I'm interested in. I'm sure many of my friends were really kind of tuned into this discussion because they're waiting to know more about the menopause.
Definitely.
So doctors often brush it off, these complaints that we go to as a stress related. And any specific signs that screams louder that we need to be letting even our dogs know that, hey, no, this is not normal to me. How do we approach that?
So we touched on the mood changes, a little bit of it,
Yeah.
and then we talked about the hot flashes. So just talking separately alone, I said they are not alone. So hot flashes mostly interrupt the sleep.
Right.
So when the sleep disturbance is there and you kind of also have some mood changes, that exaggerates it, right? So if you have a major depression symptoms, you cannot attribute to normal aging or menopause. So that is you kind of feel, especially if you had a history of depression, it seems to hit them harder.
Oh, wow.
Okay. And people who have psychological stresses like social stresses kind of thing, kids going, work stress, relations, changes in the status kind of thing. A lot of those stresses kind of
add up?
Yeah.
Okay.
Add on together. So if you have a depression to the point where you kind of feel this is not normal, they need to reach in. Second thing is about hot flashes. So hot flashes are independent risk factor for cardiovascular disease.
Wow.
And then
listen to this. Hot flashes is connected to cardiovascular diseases. I want to know more. How do we know this?
So a lot of time, and I think the treatment also, when we kind of touch on treatment in future, maybe I'll kind of come to that. So a lot of time, a lot of studies done on cardiovascular in men. If you see, a lot of kind of quoted studies are there, but women, we kind of recently, as we had for menopause, we talked about. So the things came into menopause with the heart related is the heart flashes that we talk about, vascularity, seems to be related with the inflammation, and inflammation can lead to heart things. And when they talked about the hormonal treatment, which has been part of the menopause treatment, has been related to increased heart diseases, but it's kind of a myth. I'll come to that. I'm going to break that myth. And then a stroke, increase in stroke kind of thing. So that's one thing that you have to be worried about. Depression, heart problems. Other thing that is kind of not normal is what I can say about is more of the physiological fatigue and kind of slowing down and cognitive kind of decline kind of thing.
Right.
If there's a kind of thing about cognitive decline with menopause, we'll come across that and we talk in detail. But if it is a sudden, abrupt personality change, or kind of you feel, oh, this person I've seen before a month ago or 6 months ago was normal. Now she seems to not even kind of know me. That's not normal. That's not related to
Will it
menopause.
go to that extent, Doc?
No, that's the reason. These are the times
Okay.
you have to go to the doctor.
Okay.
Kind of talk about.
Got it.
But,
Okay.
So this is not menopause related. We'll talk about. So we talked about the hot flashes.
Right.
Why it occurs? Because the hormones have an influence on the hypothalamus, where we have hot and cold regulation.
Right.
So when the hormones are going down,
Yeah.
that's kind of when this are the release of those hormones from the hypothalamus center. So that stimulation causes a flash. And
What
kind of
is
thing.
hypothalamus? I'm sorry, I'm not a medical.
Okay. I know. I
What
should
would that
not,
really
right?
mean?
It's a brain center which controls, like, kind of temperature and the heat and temperature one.
Got it.
So this receptors being there close to the hormone has an influence on it. It inhibits it. Basically, you're releasing from that, causing it.
Got it.
So that's kind of there. So that's kind of what, those are the 3 symptoms I would worry about.
Okay.
And go kind of immediately talk to the doctors. In spite if doctors brush us off, oh, it's normal, they can say what was there before.
Right.
Especially with cognitive decline, it's the family members who come across and say, this is not my mom, this is not my sister.
Right.
It was kind of like, so that's when we need to kind of talk to the physician.
So that is unconnected to the menopause, though.
Yes.
Okay. That makes me feel better. So let's talk about it, because you did mention about the brain fog. And that is one of the symptoms too, I hear, right? The hot flashes, the brain fog, in that, even the hot flashes, to me, what I've heard is it happens after midnight, sometime around 3 a.m. in the morning. Is it connected to the timing too in a day? Why does it happen only in the midnight after around 3 a.m.? And what is really brain fog means? Okay, just a little bit more about that.
So we'll talk about the night sleep disturbance.
Yeah.
So with the irritability, anxiety, hot flash, you'll have sleep disturbance. Why it happens, it's more of the circadian rhythm that we have, according to that, the fluctuation in hormonal level falling down.
Okay.
So that mostly, like, kind of thing, that sleep disturbance is occurring would kind of add on to it.
Right.
Coming to the brain fog, what we're talking about is, immediately, like, just when the person is perimenopausal, because menopause starts not just ceasing the menopause, it starts before. Right. The studies have shown, like, 12 months before you have this mood changes and all, but 20 months before you see the processing slow down. So what I can explain is, if you're learning a new language, that's a process that you have to go through. It's not as sharp as when you are kind of able to do. They kind of found it's more clear when immediately, like around 50 or 52, the processing you seems to not be multitasking. If you remember, some people say multitasking, I'm not able to do it anymore.
Done, kind of,
yeah. So actually the literature is not to go for multitasking even in young people, but that's kind of, obviously you would know, the women who could do, like, especially women are known for doing multitasking.
Right.
So it seems to not able to do that. They have to. So that affects earlier.
Right.
And then later part, like around 8 or 6 years later, you can see verbal memory and then working memory seems to be affected.
Wow.
So good news is it's a transient, and with things that we'll talk about later, what can we do for all the symptoms? We're talking about a lot of symptoms, what to do. We'll talk about that more in detail, what we have and where to go for a physician, talk to the healthcare provider. So I think, good news is it's not always. You can train things or overcome those things.
Got it.
So even the hot flashes, the median age is 1.5. So you can kind of like, but going through that, when you have those, we can go with the hormonal treatment. We'll touch on it if we have time permits.
Yeah.
And then we'll talk about what we can do kind of doing it. So
that takes me to HRT, the hormonal replacement treatment.
Yes.
It's getting all the headlines lately, right? But is it safe? And there are people, like, my own colleague, one of my colleagues was talking about this, and she's worried about HRT too. Are these cancer fears too with HRT? And please give me the non-BS.
Yes. Sorry. So let me talk in that way. Sorry,
Yeah.
if I had kind of gone into too medical terms, you
Yeah.
you always kind of pause me because, it's kind of talking too many times with the medical community.
That's
You know, you
natural
can-
for you.
Yeah. So if you check hormones, the estrogen has a lot of receptors all over your body.
Yeah.
The big two are the uterus and the breast.
Mm-hmm.
Okay.
Mm-hmm.
And then, in the brain, prefrontal and frontal, that's where the cognitive comes in. The receptors, frontal is here,
Okay.
where our executive functions are.
Mm-hmm.
And then the hypothalamus and all that is kind of there.
Yeah.
So the frontal cognitive brain, more of the receptors being out of there, kind of not getting the receptors, getting that estrogen is not getting it.
Mm-hmm.
We have it on the
I'll
bones.
call
and-
this as a third eye.
Yeah, or kind of third eye or
Yeah.
concentration, cognition kind of thing, executive functions, you do it kind of
Okay.
thing. So we're talking about HRT. So there was a big women health initiative in the 80s.
Mm-hmm.
They talked about, having the people, they had a three spokes kind of study people group.
Mm-hmm.
One of them were the people who had a hysterectomy or ovaries taken off, early
Okay.
menopause people.
Okay.
People in the middle and the people in later.
Okay.
So when they found those people put on the estrogen and progesterone, those are the two hormones we talk about for the treatment, HRT.
Mm-hmm.
So estrogen is earlier part of your menstrual, like if you know the regular menstrual, and the progesterone acts towards the later part, and both dropping down, that's where the menses occurs. And those
Okay.
two are the hormones that are going down
Okay.
as we get to menopause.
Okay.
So when you look at it, the estrogen wing with the progesterone wing, they found those people having incidence of heart attacks, breast cancer, and clot, DVT, they
Okay.
clot in the deeper
Yeah.
vessels, which lead to stroke.
Oh,
So
wow.
was increased. This was
That is for the people who are
hormonal
undergoing this hormonal replacement treatment. Okay.
but it was over the duration of 20 plus or 10 plus years maximum.
Mm-hmm.
And the group that they were affected were the older women.
Okay.
So the older women we're talking about is anybody above 60. The average, I think, median age was around 65 or 68.
Okay.
So we're not talking about that set of people here. We're talking
Right.
about menopause, where 45 to 55.
Okay.
And early menopause is also there. And
Yeah.
people, some of them have an early ovarian failure, they call it.
Mm-hmm.
And those people below 45, and people who had a hysterectomy
Mm-hmm.
with the ovaries taken off,
Right.
those people, there was a clearly benefit.
Okay.
So if these people and under 60,
Okay.
a woman getting hormonal treatment,
Mm-hmm.
clearly from that studies and the recent last 22 or 3 decades, we have
Right.
been a lot of big
Yeah.
studies from Europe, all over the Australia, and even here.
Yeah.
They have clearly seen a benefit. 1 in
Got it.
7 women, less death. 1 in 8 women, less heart attack.
Okay.
And the breast cancers, even high risk or moderate risk. High risk, I would ask them to talk to their health physician.
Right.
Seems to have no risk, safe for 5 years to
Got
be
it.
on hormonal treatment.
Got it.
And a lot of our symptoms which we are treating
Mm-hmm.
is in those duration time
Okay.
that we kind of do. So we are safe.
Okay.
In fact, we benefit, especially earlier, younger women
Yeah.
who have earlier symptoms to have a clear benefit.
Got it.
So the other thing that, before starting, if you have an older woman
Yeah.
who says, oh, my mood swings are very high, I cannot live without hormones.
Right.
What you have to do is make sure you do what we call it as ACVD score, atherosclerotic cardiovascular disease score,
Okay.
which tells you have a high risk for heart problems.
Mm.
So if they have anything below 5 safe,
Mm-hmm.
you can still go ahead and get them
Right.
and kind of follow them.
Right.
Saying so, there is a slight risk of the clot,
Mm-hmm.
deep clot, even in those people. That's why when you go to the healthcare worker who kind of gives you hormonal treatment, if they have to evaluate them for risk for any kind of clot. If they have any kind of clot, they maybe go with non-hormonal treatments which
Right.
are available.
But is this HRT can be undergone, let's say, in the age of 40 to 50, or is it an age specific?
No, that's
There's
it.
no age.
Anybody under 60 can be safe to be
Got
there.
it.
And
Got it.
even the HRT medications have gone through a lot of changes.
Got
We
it.
are using the progesterone, which is micronized progesterone.
Mm.
Earlier was just medroxyprogesterone, which had more of the clot and the other things that we talked about risk.
Right.
Even in the estrogen, transdermal patch is safer.
Got it.
And then we didn't talk about the local genitourinary symptoms. So, and the sexual dysfunction. So that we can even go with the local treatment for that, which are being safe. Even
Got it.
people who have breast cancer, local, transient, they can be
Okay.
safely treated.
This is very helpful. Very interesting for me too. So for women ditching the HRT, let's say they've undergone and they ditched the HRT, what quick signs, I don't know if science is even going to tell us, can it be handled via the mindfulness activity, via diet, via any other thing, safer? They've undergone, but they've ditched it.
Yeah. So what I say is, we talked about hormonal treatment.
Yeah.
That's not the only thing.
Yeah.
You know, it doesn't say every woman have to be on hormonal treatment.
Got it.
Okay. So there is an option, non-hormonal. But even before we talk about, we have to talk about, the physical decline, and people get diabetes, obesity, kind of gaining weight kind of thing, mood swings, hot flashes, right?
Yeah.
So if we do that, what is that helps you? First, acknowledging that we have those symptoms. So this is what we are kind of talking about. I think whoever listens to it.
Whoever is listening, acknowledging that something is changing in your body is important.
Yeah. Adapt.
Yeah.
What is that you can adapt that you had before? Is eating healthy, more fiber, more fruit and vegetables, active. Okay? Active in a way is you can be two ways. One is aerobic.
Yeah.
Especially it's good for the bones. We didn't touched on the menopause and the bone or osteoporosis or bone fractures. But it's kind of more. And also regular moderate exercise. So how would I know this is moderate exercise?
Yeah.
If you're walking, even with your friend, if you're able to talk, not able to sing, that means you're moderate.
Got it.
High intensity is fine. If you are a person who likes to run, who need to do high intensity, how would you know this is high intensity? If you're walking, you're able to whisper, but not talk, not sing. And what is really, you need to push yourself when you're walking. You are able to swing and walk. That's not exercise. That's you. I mean, it's good. Still, you're moving, but the moderate to high intensity. So you have to exercise. You need to eat. And people who have a socioeconomically disadvantage seems to have a little bit more. People who have a psychosocial stress, they need to. So mindfulness. Anything, yoga, tai chi, anything physically you can do. Meditation is another one. So you need to kind of find what works for you, and important is being with the family and friends, and giving something to community. All this, you being active, kind of you can overcome, because those things some way help you. Endogenously, hormone-like might be something that is coming in, and a lot of other cardiovascular as well as a lot of benefits out of that kind of things there.
There's so much connection in here.
Exactly.
So while you were talking about this, Doc, I wanted to touch a little bit more upon you said about the bone fracture connected to the menopause.
Osteoporosis.
Yes. Is it menopause related or non-menopause related?
Yes.
Okay.
I mean, a lot of people know about the osteoporosis and bone, hormonal, what we talked about, and hot flashes to some extent, because 80% of the women get to. 10 to 15 may have a severe symptoms. A lot of things, mood swing, a lot of time they say women, PMS, hormonal. So a lot of time they are kind of tended. So that's what we talked about. The bone is well known kind of in the past. So basically, we start losing our bone mass. What we call, a bone has two things. One is a softer one, which is a kind of can bend it kind of thing. Kids, when they break their flexibility, when they break, they can fracture, heal well. Whereas in the older people, they're brittle. Right? So what we're talking about is brittle bones.
Got it.
So that soft, fatty thing and that matrix that we talk about, the soft cushioning thing, that bone has a strengthening, which can bend, but at the heel is kind of lost when the estrogen is kind of taken off. The bone loss occurs even before you start menstruation, 12 months. But a lot of time you don't talk about screening them at least till they are age 65. You can say you're saying menopause is 45 to 65. Why wait
And
then?
why wait then? Yeah.
There's some risk factors you have to do earlier. The reason is you start losing your bone, like at least 2 or 3% during the first 3 years of your menopause or perimenopause menopause transition, around 2%.
Yeah.
Really, your bone gets brittle is when you lose 10% of your bone mass.
Got it.
So that's when the bone becomes porotic and brittle. And even a subtle thing that can break, and 2 places where women kind of have is spine and in the hip.
Wow. Yeah.
So that's kind of where.
Spine is your main whole thing for you to
So
have
especially for
function.
that.
Yeah. Wow.
So
what do we do for that?
So a few things. Vitamin D, like, especially being in Michigan, I think, if people think it, we don't have enough sunlight, neither we kind of sun exposed, right? So level safer is about 35 is kind of 30, 35 is kind of good, but anything about 20 seems to be okay, but you can have to get more, either supplement or, kind of make sure that you are more into sun exposed. Resistant exercises seems to be helping the bone.
Okay.
So more of, at least couple times, the moderate exercise, the recommendation, even like we're talking menopause or anything else for a normal person, is 150 minutes, kind of like, over a week time. But couple times you have to include resistant exercise around 30 to 45 minutes.
Got it.
So that seems to help your muscle mass as well as the bones. When you have a good muscle mass, that's a cushioning for the bones too.
Got it.
And the same thing would kind of prevent you from obesity that happens in the transitional age.
So when we talk about obesity, I just want to touch one more point on the menopause itself. The weight gain is so normal during I don't know if everybody undergoing the menopause will gain weight, but that is one of the symptoms too. Do we want to fight that with any diet, or do we want to just accept the fact that this is normal and let it go? How do one see that?
So if you look at it, I think, it's kind of if we kind of talk about weight gain or obesity, it's a talk of its own.
But we'll have to talk about the obesity in my next topic. Not today.
Definitely. What I'm trying to tell you is there's a hormonal change occurring, right? So there's an increase in, I talked about lean mass and kind of thing. Lean mass is basically muscle mass.
Yeah.
And fat is a fat mass.
Right.
So you're replacing the lean mass with the fat.
Yeah.
That's happening at the same time in your body, more so in people who are obese. Okay. The people who are kind of have a poor health, physical health, like osteoarthritis, and kind of have diabetes, high blood pressure, hypercholesterol. So this all happens in the middle age kind of thing. So those people seems to have more
prone to be gain weight. Yeah.
So and people who have a low stresses, like low social economic status, because you're not eating healthy. So part of it is like, if you start being aware of this and being more active, lifestyle changes you make it and kind of they seems to have less weight gain.
Oh, that's...
And in a way, adiposity, and if you kind of want, it'll be away from a talk for 30 seconds.
Oh yeah, totally.
We women can bear kids, right? So our fat is more in the abdominal area.
Right.
And that's protective during the reproductive age. But it's a fine line between that to the point where it becomes, because once the obesity sets in and adiposity starts getting in, it becomes an inflammation in your body. Oh. And that's not good. And that fat in the abdominal is not good. It increases your what we call it is a waist to abdominal measure, which is an independent risk factor for cardiovascular. So so it's kind of related, all of this, and well-being, mental, physical, psychosocial, everything is kind of so connected. But I think the simple thing to the life is more grains, more fiber, more fruits and vegetables, eat simple, eat when you're hungry, and less calories and more active.
Totally.
So
wow.
It's kind of like, that even kind of takes care of a lot of
many
problems.
of these issues together.
Issues. Yeah.
Wow. So we talked about how the estrogen gets lower during our menopause phase and everything. In not only that, like we women are who are working, and I call myself like, I have 2 or 3 jobs, because one is your real work that you have to work at your whatever we do, Plus, we have to take care of the house, like, the kids and have these multiple jobs, right? So, is a reason for us to lose the desire for a sexual activity? I mean, in the sense, like, that the whole thing will go down, and I don't know if it's truly connected to the menopause, the drive, or is it truly something, is it the age, is it the menopause, or what is it?
Actually, your question, I had the answer in it. So when you talk about sexual activity in women,
Yeah.
You're talking about desire, you talked about,
Yeah.
and and then what do you call, orgasm, kind of the act, like, more on, and also the emotional kind of
Yeah.
thing, right?
Yeah.
And then the painful,
Mm-hmm.
like local symptoms because of the estrogen withdrawn.
Mm-hmm.
So hormonal influence is only when the genital area. What we talk about is for estrogen loss, the vagina or the mucosal gets drier, atrophied, and then painful.
Mm-hmm.
We call it as a dyspareunia, like painful sexual activity.
Right.
It's only thing that's kind of hormonal related.
Mm-hmm.
A lot of other things that you talked about, sexual desire, actually 1/3 of the women in the earlier part of menopause to the postmenopausal, at least 60-70% of them seems to have those.
Okay.
And as we talked about the multi-juggling, other things, stresses,
Right.
depression, sleep problems,
Yeah.
hot flashes, everything added onto it may be contributing to those kind of things.
Mm.
And also relations wise, so the
Right.
difference in the relations, because each
Right.
partner will be like some of them will be successful, there will be a gap in there.
Right.
So a lot of other things may play a role,
Okay.
because they clearly found in people who had a breast cancer, usually we go with anti-estrogen therapies sometimes with the when they have a hormonal related breast cancer.
Right.
They didn't see a change in those kind of things. Only
Okay.
thing that can be is a local symptoms, what we call
Right.
it is a genitourinary symptoms,
Mm.
and local estrogen is a treatment.
Mm-hmm.
And one thing I talked about, other symptoms getting better, but genitourinary symptoms, unfortunately, until you give a small dose of estrogen,
Right.
would not. So lubricants sometimes help, but you need to go with a local treatment for those
Got
symptoms.
it. So we talked in your answer. You also touched about, we're going to have a sleepless nights. I mean, you can't really sleep. Is it also connected to menopause?
Yes.
Okay.
So insomnia, insomnia or sleep disturbance, we call it. It's not a deep sleep. You don't feel like you're freshened, kind of thing, and all that.
It's
Kind of part of it. And the hot flashes may be a one thing, but sleep is also an independent one.
Got it.
And not much studied, but now it's coming in is the musculoskeletal changes that happens.
Oh.
A lot of people have this arthritis,
Right.
kind of thing, stiffening of the joints,
Yeah.
not motivated to kind of do, and the osteoarthritis sets in, but that's more of the later time.
Okay.
But they are kind of saying the bone estrogen is also like a receptors in musculoskeletal area.
What should we do for that?
Same thing, lifestyle changes,
Okay.
physically active, be active, push
Okay.
yourself, because I think, if you follow Eastern philosophy, they talk about energies in the body. You have to
Yeah.
activate them.
Yeah.
I think it's more being active,
Right.
both and to kind of join, that would help us.
Okay. And I thought, it's not going to be good if I just talk about the woman. Just one last question about the men, too. If men lost testosterone, oh my God, I can't even pronounce
They do
this.
lose testosterone. Yeah.
Testosterone. Like we lose estrogen. Would science care more by now? And how do we demand better research?
So I think, I'm glad that you brought it. It's called menopause, so it's andropause, we call it in men. It's not identified as kind of thing because,
I've never heard this. I want
Yeah.
to just say it again. Andropause?
yes, there's a term.
Andropause. Okay, there's a term.
I said that for the last 3 decades, we have a lot of studies on menopause, right? But we don't have much. I mean, it's coming now, but it's not that as prominent as kind of that.
Right.
Why? Because, they also get at usually 45 to 55, and men, it's sometimes maybe a little later part of it.
Okay.
They lose the testosterone. A lot of it is talked about losing testosterone, checking testosterone, getting testosterone supplement,
Yeah.
injections.
Okay.
In libido, loss of libido, which happens in women too, but in men,
Yeah.
because the sexual activity more of an active role, and men kind of always identify kind of that erectile dysfunction, loss of libido can happen in men too. Osteoporosis occurs, but their risk is more towards at the 75. So we screen them around 75 for osteoporosis.
That's not fair. Why women so early?
Because we get more fractures. So loss of bone is pretty active in women. Compared to the men kind of losing it. Because if you see testosterone muscle built, like, kind of related, so their loss is not as kind of like, kind of thing. Their fracture risk is more in the spine. It's increased after 75.
Got it.
So, and then we kind of do, in women, it's two places. We talked about hip and the spine. So that's kind of why. They also have more changes. Yeah. And then also have the insomnia. All the things that we talked about subtly, you find them on it. But I think, women multitasking, as you talked about, which I would not encourage, but I know being multiple places and cognitive. And I think women also talk to other women more commonly than men talking about men.
Right.
Because, I think that's kind of why it's more talked about, and famous people, as I talked about, bringing that into their talks. Menopause has been in the media recently for a lot of reasons.
Absolutely.
But men do have it, and I think, I hope they have. I would say here women have got better research, menopause one.
Right.
Andropause is coming in because it's not talked about by men.
Right.
And also the researchers. But I think, what we have from this Swan study 30 years ago, I think we use a lot of those to the men. It applies to.
Okay.
Yeah.
That's really interesting.
Yeah.
Doc, this was a power-packed discussion for me.
I hope.
And a lot to take away from me too. So the one main thing that will remain from this discussion is a lifestyle change is so important for us. A lot of fiber, movement, and keep yourself active so that you can, a lot of these other things will be coming together.
Yeah, adapt
to this new.
You can't just be what you were before. So you need to adapt to the lifestyle. And too.
Right. So this was wonderful, Dr. Doc, and more to come. And I would like to do more with you on obesity, maybe the next topic. So we'll do more. And Dr. Kesari, wonderful to have you on the KTU.
Thank you for doing this, and thank you. You are a wonderful person.
Oh, you too. You too, from what I know, and really appreciate your time today.